Well, hello, everyone, and welcome to Dementia Unplugged. I'm Jeannine Forrest, and I'll be facilitating today's sort of discussion on how to respond to hallucinations, delusions, and paranoia. So thank you so much for taking the time out of your day to listen to this webcast. Please know that these are recorded. When we come to the question and answer section, what happens is I then turn off the recording so that we can maintain privacy, and I only use your first name. So before we get started, I want you to hear a message from Kevin Jamieson, who's the president of Dementia Society of America.
Welcome. Please listen to this important message from the Dementia Society of America. All content, including any potential medical information, is provided as an informational resource only and is not to be used or relied on for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. The opinions expressed and the content shared by Dr. Forrest are not necessarily the opinions and content of the Dementia Society of America. Thank you.
The way I like to start these podcasts is to give an overview of what we mean by dementia so that we're all kind of thinking along the same lines. So think of the word dementia as an umbrella term. Similar to the word cancer, there are many, many different types of cancers: lung cancer, breast, prostate. Very similarly, we're learning that there are close to 400 different conditions that would contribute to this term called dementia. And the most common that you probably know of are Alzheimer's disease, vascular dementia, Lewy body, frontal temporal. Certainly you can have a mixed dementia. So this can be a very complicated kind of understanding, but I did want you to know that there are many, many different subtypes. So when we're talking about the problems that come along with hallucinations and delusions and paranoia, some of these conditions happen more in some dementias than not, and we'll talk about that, but it is appropriate for all. I want to start out by giving a definition to the word hallucination. So hallucination basically means that there's a false perception that's taking place primarily through the senses. More than likely, and the one that I've seen mostly in my clinical experience, is that people have visual or auditory. So they see things that don't exist, or they hear things that don't exist. And this hearing can take place sort of inside one's head or outside. You should also know, although it's a little less common, that all of the senses are impacted by these hallucinations, and you can have olfactory or different smells that don't exist, or tastes that change, or a perception on the skin that bugs are crawling over the skin. So every sense can be impacted by these hallucinations, but what's most common are the visual or auditory. That said, not all hallucinations are created equal. What I mean by that is that some can be very threatening and scary, or some can be non-threatening at all. So I've worked with my clients who've had visual hallucinations of just beautiful butterflies floating through the room. Not scary at all. They were fine with it. And so that approach is going to be very different than if I have a client who sees a monster in the curtains or in the wall. So please know that not all hallucinations are created equal. And it's really the threatening ones, the scary ones that we need to be most concerned about. When we look at causes of why these hallucinations take place, it's important to really get this checked out by your physician or medical provider first, especially when they're starting, because hallucinations, delusions, paranoia can really come from two big buckets. One, in a sense, from an underlying sort of urgent medical condition that is started by a variety of factors. So it could be the beginning of a bladder infection. Change in mental status is one of the hallmarks that happen with an underlying type of infection. Intense pain can cause hallucinations. Medication side effects. If one has impaired sight or hearing and you have a distorted sense of what's happening in the room, hallucinations, visual hallucinations or auditory can be more pronounced. Certainly the abuse of alcohol or drugs. So I can't emphasize enough that we first need to have the person you're caring for checked out to make sure that there's not an underlying medical problem that can be reversed. And the terminology or the term used for this is delirium, sometimes also referred to as acute confusion. And this delirium can be superimposed, meaning put on top of their baseline dementia. So if you have a loved one whose general behavior is sort of calm, not seeing these things, and then all of a sudden they come up with these stark, intense types of hallucinations, along with the inability to pay attention and anxiety, that's more likely a delirium that can be reversed. That said, unfortunately, these hallucinations and delusions and paranoia can also take place just because of the brain changes that are happening because of the different dementias as well. So, it's especially if you're in the beginning of this and caring for someone, either as a professional or as a family care partner, this can be really scary. And so know that you're not alone, and don't try to figure it out on your own, but try to get some help. But I'm here today to really talk about when we kind of have a sense that this is really happening from the dementias themselves. And the reason it's happening is because the brain tissue is changing. What I have on my slide is a picture of a brain with frontal temporal dementia. You can see on the left side, that's the frontal lobe, in which the tissue is really shrinking, and within it there are abnormal proteins, and there are parts of the brain that are responsible for the way we perceive through our senses, and that is really being distorted and destroyed. So people have what we call a visual spatial decline along with these abnormal proteins. So these are the underlying reasons that we understand currently in our scientific understanding of why, if there's not a delirium underneath, why this is happening with the dementias. So the dementia subtypes, that I've come in contact with that seem to have a propensity towards these hallucinations are Lewy body dementia in particular. Can also happen with Alzheimer's, frontal temporal, vascular, Parkinson's related. But one of the hallmarks of Lewy body dementia are these hallucinations. Not too long ago, I cared for a woman with Lewy body dementia, and every visit, she would tell me about these little green men who were outside her window riding bicycles, and she could describe them in just incredible detail. And they were consistent and persistent throughout her dementia. Now, interestingly, they were not scary to her at all. But what were, where she was seeing 3 children in her room who would just stand and stare at her. To her, these 3 children who would not speak but just stare at her were incredibly frightening. So what I want you to know that these hallucinations are very, very real, very, very vivid to the person experiencing them. So what helps when we've ruled out the fact that there's not an underlying delirium, infection, those kinds of things happening? Always start with the non-drug approach because medications in and of themselves can cause a whole host of problems. And so that's why I'm hoping you're tuning in today, is to learn what are those sort of non-drug approaches. First of all, the way I started out, check to see if it's a positive or a negative kind of hallucination in general. And also check out, is it really valid? Sometimes people will see that, well, there's faces in the window. Well, it can be that there may be someone walking by, inadvertently staring in. So don't always negate up front that that this quote hallucination is taking place. So do due diligence in terms of checking this out. That said, your role, and it's not easy, is to stay calm. People with dementia absorb your feelings, your tone of voice, your facial expressions. So if all of a sudden you're becoming more anxious and upset, people will take that on no matter what you say. So it's really important that you stay as calm as possible. I always take 4 deep breaths. If people are telling me about their hallucination, I quiet myself first. And first and foremost, do not argue. Do not say, oh, they don't exist. Don't negate off the bat. What's helpful is that you say something like, I know, Mom, that you see the Loch Ness monster in the curtain. I do not, Mom, but I know that this is very real to you. So you've acknowledged the fact that they see this. Quite often, this is not intuitive. We want to protect our loved one or the patient or the client or the resident. And so our first reaction is often, no, that's not there. No, you're fine. You'll be okay. And people learn then that it's harder for them to trust you. And this is where the paranoia gets set off. So it's important, first of all, start out with acknowledging that this is real to them. And then we're going to go forward with responding to their underlying tone within their distress with compassion. What else helps? Because we are working with distortions in visual spatial centers of the brain, Be sure that if a person does have glasses or hearing aids, make sure they're in place because sounds can get distorted. Certainly, if people aren't seeing correctly, there can be changes in perception, looking at shadows, things like that. Another important piece is to turn on or turn up the lights, especially if it's towards evening and there's shadows. Shadows on the wall during the evening can cause all sorts of hallucinations. Using night lights in the bathroom or the hallway. Some of you know that I have family members with different types of dementia right now. And currently, a family member in the middle of the night is sure that his wife is bringing in lovers into the home in the middle of the night. When in fact, when we've traced all this, certainly that's not the case. And this is more of a delusion, and we'll talk about that. But his perception is when she gets up to go to the bathroom, the way she looks like an intruder into the room. So we installed a whole variety of night lights, and that certainly dissipated this hallucination. Another helpful hint is to cover mirror, particularly if people are seeing different things in the mirror, or it may be the occasion that the person doesn't recognize themselves. Now, this is not a true hallucination, but this does come into play on occasion, where the person has sort of a timed sense that they're much younger than their older years. And this too happened recently, where an older client of mine in his 90s was looking in the mirror and was sure that there was some old man in the bathroom with him, and he wouldn't go. So we had to cover the mirror. Other things that help is to sort of distract or break up those senses. So meaning playing soothing music to prevent an underlying infection, keep the person well hydrated. Also, dehydration can cause mental status changes and hallucinations too. So once you've acknowledged this person and their hallucination, try to distract, change the environment, change their activity, try to get them to do something else that grounds them in a different sensory experience. There are times when the hallucination is persistent, and I see this more than likely in the anxiety and the distress, and a person can become combative, particularly when there's a delirium. And it's okay to call for help, call your medical providers. In some cases, if a person becomes a danger to themselves or others, this is when you can call 911 if you're home. So there is always an outlet. There's a safety net to bring in more assistance. I talked about medications. These are certainly the antipsychotic medications, the sedatives. They have a whole host of side effects that are not always helpful. And so I'm not going to spend this episode talking about medications because it's just too in-depth for our half-hour time together. But do know that often this is not the first line of defense. You want to try all of the non-drug approaches first. And some of the typical antipsychotics, for example, Haldol, is one that's often, it can be used, but it can cause a lot of detriment to people with Lewy body dementia. So even the antipsychotics are not all equal depending on the type of dementia. So that gives another reason why it's important to really fine-tune the diagnosis, because not all dementias are the same. I want to move on to delusions. And what is a delusion? A delusion is a false belief, even with evidence to the contrary. So some people have a false belief that they're the Queen of England or Miss America. Or more commonly, the delusion is one of infidelity, or that the person is stealing. Just like hallucinations, delusions can also be positive and negative. I'll give you an example. I was working with in a long-term care facility, and one of the residents was sure that she was a very, very famous author. And she would, tell everyone how she would fly around the world and do these book signings. And so, in essence, this was a delusion that did not hurt anyone. And so this did not necessitate a medication because it wasn't frightening to her or to others. This is important. So the delusion that she was a famous author, in order to decrease her anxiety about this, we would actually have her bring up a desk with books and have her sign them. I always say that if I have the delusion that I have Miss America, please let me have that delusion, okay? I'm not hurting anyone else or myself, but in fact, when the delusions become frightening or there's a sense of infidelity, that their spouses, their partners are cheating on them, this can cause a lot of distress in relationships, or that someone is stealing from you, or there are people out to kill you. This is when we really need to take more action. So what helps? Similar to hallucinations, it's important to listen, pay attention, take those deep breaths, and do not argue. This is where we have to respond with compassion. Pay particular attention that your tone of voice, your facial expression is one of concern, one of interest. You can try reassurance first. So, for example, Mrs. Smith, no, I did not steal your purse. I did not steal your money. And look, as convincing as possible, because we know you didn't. We know that you didn't. We can sometimes bring other people in to reinforce this, other sort of bystanders or people that they trust, to say, no, that really did not happen. But with delusions, they are so prominent, and evidence to the contrary will not always convince. So when that happens, I find apologizing for the stealing part can actually happen and help. I'm so sorry. I must have misplaced your purse. I am so sorry. I didn't mean for you to think I stole it. And people have a hard time arguing when you're apologizing. So the apology is helpful to address their distress. You're not affirming in a sense of saying, yes, I stole it, but you're affirming that you're just so sorry that they're experiencing it this way. Another helpful way of going about this is because quite often what happens is people misplace their things and then they're sure someone stole it, is to maybe have multiple models, replacements available. So if you can't find them, then you can have sort of another backup. The infidelity one I want to spend a little more time on, because this is where it causes all sorts of havoc in relationships. And interestingly, what may be happening to no faults of the care partner, the spouse, the partner, um, people, because we're human, can pull away from our loved one with the dementia. Everything seems turned upside down and we don't know how to love them anymore. And it's scary to be accused of not being faithful. And so there's a tendency to distance ourselves. And so there may be fear. And so you might find, if you kind of go through your mental checklist, that maybe you do hold hands less, or maybe you do say I love you less. Maybe you're always saying don't, stop, can't do that anymore. And so everything comes at them as negative and not affirming. And so there's this perception that you don't love them anymore. It's the perception of sense that you're pulling away. So one way to address this, when we come to infidelity, you're cheating on me, is to acknowledge what they're saying. Don't negate it off the bat. Say, I hear that you're telling me that I'm having an affair. Next, affirm, not the affair, but affirm, honey, we've been married for 50 years. Look at this ring on my finger. I love you so much. I can remember the day that we got married and go into some detail about a loving experience. And then use a form of love that they have come to know in the past, or that is familiar to them, to distract. Let's say that they love chocolate cake. Come on, let's have some chocolate cake together. So you are moving, distracting that conversation with something that they love and enjoy. There's a book I would recommend called Keeping Love Alive as Memories Fade, The 5 Love Languages and the Alzheimer's Journey. Now, this can happen with any of the dementias particularly. This information is useful, and the authors are Deborah Barr, Edward Shaw, and Gary Chapman. It was printed in 2016. And so they go in to talking about the 5 love languages. And this is so apropos when we're talking about the delusion of infidelity. So people need to not hear I love you, but they need to feel I love you. This may have been your own experience. Have you ever had a loved one say I love you and it feels empty and it's just words and there's no emotion or action behind it? This is where we really, as care partners, as spouses, as partners, need to put it into high gear to figure out ways that have been important to that person with dementia. What are their love languages? And what does that mean? Have they responded well to words of affirmation? You are so beautiful. I love those blue eyes. Wow, I love how you I love the sound of your voice. Or is it quality time? Some people, words aren't so important. You can say all you want, but are you spending time with me? For some, it's receiving gifts. And I have to admit, this is my love language. I grew up with my mom giving me little gifts, not fancy, it might have been a cough drop or something for that day. So know what your love languages are. Write them down. Go back and think, what was it that excited my spouse? Is it acts of service? Is it polishing someone's shoes, or is it making someone coffee in the morning? Or for some, it could be physical touch, a gentle, stroke of the hair, holding hand, rubbing someone's shoulders or feet. So the five excuse me, love languages really come into play here, to help that person feel and know they're loved. This is so hard. Know that it's the disease that is speaking. And, when you're so close to someone, it's really hard because we don't see that brain changing underneath the cranium and inside the skull. And so when they say hurtful things, it's so hard not to take it personally. So I often encourage people to look like their loved one has a big bandage around their head, to try to not take it personally. And the important piece is to take care of yourself. Reach out to others. Do good things for yourself in order to replenish your own spirit, in order to love someone intentionally when they have dementia and these delusions or hallucinations. Paranoia. Paranoia just means extreme distrust, and it often comes from the delusions that are unmitigated, or the hallucinations where people automatically say, oh, no, you're not seeing, no, of course, what's wrong with you? I don't see the bugs on your skin. What's wrong with you? No, and if people hear this, they become more and more paranoid because in their mind it's so real. And can't you see those children next to me and they're scaring me? And if I were to tell this client of mine, oh, of course they're not there, she would have become more and more distrusting, more and more paranoid, more and more distressed, to the point of maybe needing a further medical intervention. So please know that some of these can be mitigated or stopped or changed based on the caregiver's approach. So with paranoia, stay calm, give that person space. You may need to just walk out of the room and come back again when you're ready to deal. So it's the compassion. I'm so sorry you feel that way. Use the strategies of acknowledging, affirming what you and love about them, and then distracting them with love languages. So I want to end by saying the ability to receive emotional love endures far longer than the ability to express it for people with dementia. I'll read that again. People with dementia can receive emotional love until their last breath, but it's much harder for them to express it over time. So the onus is on us. And it's not easy. It's not easy. So that's why you're here. That's why you're in a community of people who are in Dementia Unplugged, who can understand that, we can have these difficult conversations and know we're not alone. So we're learning to care before finding the cures, because there are so many different dementias. I do want to tell you that I am available to you if you would like to have a private consultation. I've actually changed and added a new service called Dementia Coach on Call. And so that is dementiacoachoncall.com, or you can call me at 773-704-1834, and we can have a discussion if you'd like more specific information that relates to your particular care situation. All right, I want you to start bubbling up your questions. And as you're doing that, I do want to give credit to the Dementia Society of America for being the host of Dementia Unplugged. It's a wonderful organization with a lot of material for caregivers. So please take a moment to look through. If you have the ability, please donate. It's a great cause. And I'm going to be turning off the recording with the next slide, and then we'll start your questions. But I do want to thank you so much for joining me